Delegates, a very good afternoon to you all. So ICL as a whole, it's not as popular as the other refractive surgeries. So in my presentation, I'm going to say that how I incorporated ICL in my practice. ICL is a phakic intraocular lens. I'll be specifically talking about the posterior chamber one because that's the most commonly used and that's what I have been using. And where is it placed? It's placed right behind the iris with the haptics resting on the ciliary sulcus. What powers are available? Myopia, it can correct up to 20 diopter, with astigmatism up to 6 diopter. And the newer ICL, this is new, that it can even correct hyperopia up to 10 diopter with astigmatism 6 diopter. So let's have a look at the candidates who are suitable for ICL. Those patients who have very high refractive power, or they have a thin cornea and are not suitable for LASIK, or the K value is too steep or too flat, these are the patients that can go for ICL. Age is around 21 to 45, we'll keep it to that, and the refraction has to be stable for 1 year. And no other ocular pathology would be better. So once we have selected our candidates, we'll go for the preoperative assessment. We need to do a complete ophthalmological assessment, which includes an uncorrected and best corrected visual acuity. We'll have both the manifest and cycloplegic refraction, slit lamp examination. IOP measurement is important because if it's high, we would avoid ICL. And two things which is more important is the angle evaluation because we need an open angle for ICL, and also in the fundus, we need to check the periphery for any lesion and correct it before going for the ICL surgery. So an array of investigation has to be done. That is the corneal topography, biometry, endothelial cell count, and the last two, that is the most important, is the anterior chamber depth. It should be, for the starters, should be about 3 mm. But once you are in the habitude of using ICL, it can go down to 2.8. But ACT is important, and the next is the white to white measurement. I use the digital caliper to measure the white to white, and you can cross-check this value with the ILMaster or the Pentacam white to white. And now we also have the UBM, although most centers don't have it, and this directly measures the sulcus to sulcus measurement. Now ACD and white to white, why is it so important? Because this will determine the size of the ICL and will determine the vaulting. So what is the vault? As we can see here, that it is the distance between the ICL and the anterior capsule of the lens. So this distance should be about 500 microns, and the range is from 250 to 750 microns. What happens is, if it's undersized, what will happen? It will touch the anterior capsule, leading to a cataract, and it's oversized. What will happen? It will push on the iris, the angle will be closed, leading to a raised IOP. That's why the vaulting is so much of importance. Once we have done our investigation, what we'll do is just put in the data in the calculator given, and then we get a map like this. As we can see here, that my patient had a refractive error of -11, but his corneal thickness was 520. So I didn't go for LASIK, I opted for an ICL instead. Once the measurements are done, we'll go for the surgery. In the surgery, I'll emphasize on two things. At first, when we are starting, please have someone who has done it before with you, or have the company people be there. Why? Because the loading is a bit different. At first, we fill the cartridge with two things, that is the BSS and the viscoelastics. And this is the bottle for the ICL. This is a very, very soft, thin lens, and there is no second one. So we have to be very careful not to damage it. With the soft tip plunger, take it out, put it in the cartridge, and now we make sure that the center is right at the center. Then we take the holding forceps, and this is a front-loading lens, so we slowly pull it towards the tip in position. So again, I want to emphasize that since there's only one lens coming, so we have to give some more time and do it very safely. Once this is done, we'll put it in the injector, and we are ready to put the lens in the eye. As I was saying, that toric ICL is also present. So before going in, we mark it, do the side ports, put in some viscoelastics, and then make the main incision to deliver the ICL. The second important one was the loading, and this is the delivery of the lens. Over here, we will also take 1 extra minute. Why? Because the position of the ICL is very important. If it goes upside down in the eye, what happens? We have to take it out again. We can't rotate it. So be very, very careful. Take an extra minute, slowly, gently push it in, let it unfold. Once it has unfolded and you have seen that, yes, it is in the right direction, only then fully implant the ICL. So over here, this is a real-time video. I'm just saying that I'm taking an extra minute to see that the anatomical position is correct. So once it's there, we'll take in and put the haptics under the iris, one by one. So again, over here, what happens is that the crystalline lens is there, the cornea is there, so we cannot have any damage to those. So we'll just do it gently and put the ICL in position. So number 1 has gone in. This is number 2 is going in. At first go, yes, it didn't go in, so I do it gently again and let it enter. Then comes the third one, the haptic is in. And lastly, the fourth one. But only with implantation surgery is non-over. I don't want a raised IOP the next day. So a proper visco wash is very, very important. And post-operatively, what we do is check the status of the cornea. We check the vault. In the first day, we just do the slit lamp examination, check the vault, check the IOP, and the positioning of the toric IOL. So it has some advantage of a clearless exchanges that I'm not disturbing the vitreous. So there's less chance of any retinal pathology. And over corneal laser procedure, the advantage is that very high refractive errors can be corrected. Now, the thing is that we should have all the surgeries in our bag when we are refractive surgeries. Why? So that we can give the patient the best treatment that he deserves. With this, I'll end my presentation. Thank you, AIOS, for the opportunity.
Any question from the delegate? Dr. Mahziba, if unfortunately it unfolds in the opposite direction, what should you do? What should be your suggestion?
Thank you. So that's very unfortunate because we can the lens inside and it might damage the cornea or the lens. So what do? Is we take it out again, then again load it and put in back in. But when we do that, we have to be again extra careful because there's only one lens available. But it's possible to do it.
Okay. And this is a costly lens. Do you have any experience with the regional industry?
Yes, since I'm from Bangladesh, so this is the most expensive one. And another one is the IPCL that's been produced in India. We used to get it beforehand, but for the last 2 years due to the COVID situation, the supply is a bit less. But when it comes, definitely it will be helpful to our patients.
Thank you very much for your wonderful presentation.